for this land.
It's time for the Kim Hammer Show, where you'll learn how your state government affects you, your family, and community. Here's Kim Hammer.
Good Saturday afternoon. Hope you like the new theme music. We're doing a little switch around here. Thought that would be an appropriate song, a little bit more hip hop there. Wake you up if you're not already awake on a beautiful Saturday. Hey, I want to start off the show today before I get into the guests that I have, which we're talking mental health, which is a very hot topic in the world today, especially here in the state of Arkansas. I've got three dynamite guests. One of them from out of state came in all the way for the show. Thank you, Dr. Corso. But I got to take care of something first that's of an election issue, election integrity issue. So I've got a statement to read and want to make an observation because we are in the middle of early voting. Tuesday, the big day for the election for the primary races. So you need to make sure if you have not gotten out to vote that you get out to vote between now and Tuesday or Tuesday at the latest, because after that it's over unless there's runoff. So here you go. During an election, it is the duty of the State Board of Election Commissioners to serve as a resource for both county election officials and the public to report problems which arise during an election. On the afternoon of Tuesday, May 17th, two voters were referred to the SBEC, which had reported to a political campaign that the voters had difficulty in selecting their preferred candidate on the ballot marking device. After speaking with the voters, staff of the SBEC traveled to both polls, identified and tested all ballot marking devices in use at these locations, as well as interviewing the election officials who assisted the voters in question. In both cases, the ballot marking devices were found to be in proper working order. A third voter has also been referred to SBEC in the first week of early voting, and SBEC staff was likewise sent to review the marking devices at this poll and was unable to identify or reproduce any defect in the voting equipment. It is essential that all voters review their paper ballot after the ballot is printed by the ballot marking device to ensure the voter selections are properly reflected and that the voter has been allowed to vote in all races for which the voter believes he or she is entitled to vote. All Arkansas voters have a right to spoil their ballot and be issued a new one up until the time the ballot is cast into the ballot tabulator, at which point your votes are counted. The voters' review of the paper ballot is one of the critical security features of all Arkansas voting equipment. In the two instances reported on May 17th and the one prior instance, the voters were able to spoil their original ballot, and the ballot ultimately cast by these voters reflected their desired candidates. Based on the testing of the voting equipment, in which no equipment error could be reproduced, the SBEC staff does not believe at this time the issue experienced by those voters caused by any systematic error or marking devices. However, all Arkansas voters are encouraged to contact the office of SBEC if they experience problems in the process voting, or they believe the voter observed or experienced a violation of election law. The SBEC is committed to taking all steps necessary to ensure the integrity of Arkansas's elections. A voter may contact the SBEC by phone at 501-682-1834 or by email at info.sbec@arkansas.gov. I'll give that to you again, and we're going to post this statement by Daniel Schultz, who is the director of the State Board of Election Commissioners, up on the Kim Hammer Show website. You can go up there and find it. It'll have the phone number on it. It's 501-682-1834, and actually some legislation that was passed this session by yours truly created a hotline phone number to the Attorney General's office where you can also call over there. They will collect those calls, those concerns, and forward them over to the SBEC, who will go out and actually do the investigating. And so the reason I wanted to read this to you was because it was reported this last week by various means that there were some election issues with some of the ballots and some of the machines. SBEC is going out and investigating those either the day of or the next day, and so far nothing has shown that it's problems with the machine. Everything seems to be working in order. We are having a higher than usual turnout for the primary, which is great in the counties that we've been monitoring and looking at. They are actually ahead of the 2018 voter turnout from the 2018. So you can go vote with confidence and just know that people are watching. In fact, I can tell you for a fact that there is one situation that's under investigation. Can't really talk in greater details, but they've already identified what the problem and who the problem is, and they're working on going after that person. You can go vote with confidence in Arkansas that your elections are secure, and it's critical that you get out to vote so that we can exercise the process of protecting and giving freedoms to future generations. I'll post this statement up on the website. You can go up there and look at it, and we're going to have a show after the election just to go over some of the things, see how some of the laws that we have work, and the things that we were able to identify where the laws paid a good benefit to making sure that your vote counted and we have elections of integrity. But today, we're going to talk about mental health issues. I got 3 rock stars, literally, in studio today. I've got Kim Schuler, who's a licensed clinical social worker. She is also the CEO of ABIN, which is an organization I'm also a board member of. So is Patty Gibson, who is MD. She is the Chief Medical Officer for ABIN. Your medical degree is in?
Psychiatry.
And then we've got Dr. Kent Corso, who also is a psychologist, correct?
Yes, sir.
All right. And he is a specialist. You're going to have to pronounce this because I slaughter it. What are you?
Suicidologist.
Suicidologist. So, and he is with the National Capital Region Behavioral Health. And so, and you're from Virginia, is that
I'm
right?
coming out of Virginia, yes,
Coming
sir.
out of Virginia. So we've got him in this week, and he's going around talking about some things we're going to talk about today with provider groups and those people of interest. And I'm going to let him promote his website and what he does here in just a minute. So you might want to get a pen, paper ready, and we'll get all that up on my website as well. I might need mental health services. This is like a free session for me this morning. Man, this is great. Okay. All right. First of all, let's talk about ABIN, just so people know who that is. And I'm going to let you two ladies talk about it, whichever one you all want to take it, so that people understand who the organization is and what we do.
Thank you, Senator Hammer, and thank you for the opportunity to be here today. Well, let me tell you a little bit about the Arkansas Behavioral Health Integration Network. We are a nonprofit. We got started a couple of years ago out of a value-based initiative called CPC Plus. And one of the things that was happening where stakeholders from a state were coming together, we realized there is a unmet behavioral health need in healthcare. And so Dr. Gibson and I got together. We started meeting on a monthly basis, and we realized we couldn't in 1 hour a month solve all the behavioral health issues. And so what we did is we came together and we said we needed to develop a nonprofit to look at how can we address these unmet behavioral health needs in healthcare settings across Arkansas. And we strategically found fantastic board members, including our own Kim Hammer. And so we appreciate your service, sir, and are so grateful for all you do. One of the things that we are doing is we're looking at putting mental health into primary care settings, and we also see ourselves doing a lot of education and training. We are a connector and a bridge for health organizations across the state of Arkansas. I also have to put in a plug. One of the exciting things that we do that really connects people across the state is we do a monthly webinar, and in that monthly webinar, anyone from across the state who's interested, we would love you to attend. You could reach out to us. These are on Thursday mornings from 8 a.m. to 9 a.m., the second Thursday of the month. And you can contact me at www.kim.schuler@abinnetwork.org, and we would love you to join us on the second Thursday of the month.
And we'll get that put up on my website, thekimhammershow.com. So all this that we're throwing out today, we'll try to get it in one more time. So get your pen and paper handy. Otherwise, I'm going to put it up on my website, and you go up to thekimhammershow.com in order to get it. Okay? All right, Patty, what's your role in? You talk about it for a second.
Yeah, I am a psychiatrist and have worked in integrated behavioral health at the VA in multiple settings, and then also been part of the Baptist Hospital system working with their primary care clinics. And Kim, as a social worker, has also worked in integrated behavioral health and other mental health settings. But the thing, ABIN, we do not provide any mental health services ourselves. Our role as ABIN is we are completely independent. We're nonpartisan. We are not affiliated with any institution or organization in Arkansas, but we are partnering and collaborating with many institutions, organizations, individuals around the state of Arkansas, as well as nationally. And we see ourselves as wanting to bring the evidence for how to improve mental health crisis in Arkansas and bring the evidence from outside. There are many states and individuals who are solving situations in their states, but each state needs an individualized solution. So we are wanting to work across the state. We're a very rural state, but then we have some different areas in terms of Northwest Arkansas, Central, and East. And so by bringing together the different partners in the state, we've got some great organizations with our UAMS and Children's and the different hospital systems, as well as some great mental health providers. And then recently gotten the Whole Health Institute up in Northwest Arkansas that's providing a lot of resources to the community. And so one of the things, too, we bring in outside experts and on our monthly webinars, which are recorded, and you can get them on our website, that we want to bring the evidence here and then work together with the other entities in the state to try to bring some solutions. And Kent Corso is one of the experts that we have been working with in one of our HRSA grants. That is a care coordination grant. We've been working with some primary care clinics, and Dr. Corso is definitely an expert in suicide and has been providing some training to our clinics and has been in Arkansas this week providing some trainings in communities. And so we appreciate you being here, Kent, and would love to hear more about what we've been doing this week.
Well, first of all, thanks so much for having me. Appreciate
Pull
it.
the mic there a little closer. You're a
Okay,
soft-spoken guy.
how's that?
Okay.
Even better. So thanks for having me. Appreciate being here with you, Senator Hammer, and with you, Kim and Patty. So suicide prevention is a cause that's near and dear to my heart. When I was an active duty Air Force officer, we had more deaths by suicide than deaths by combat. So that's what got me involved in suicide prevention and suicidology. Here for the last week, what we've been doing is traveling around to different communities, because it's one thing to train medical providers. It's another thing to raise awareness among community members. So if we are doing our jobs well, what we're doing is trying to ensure that we look out for one another, that within that sense of community, we are trying to stay aware of those around us who are struggling, and that we do sort of the right thing and reach out and try to help one another. And so there's definitely a specific effort around helping community members help one another with regard to suicide prevention.
You know, suicide, and we're going to talk about a wide range of topics this morning, but let's camp out on suicide for a minute, because recently had a friend, very successful friend, very, very prominent in the community kind of deal, committed suicide. You know, and it was one of those deals that when you talk to his network of friends, myself included, it's like, didn't see that one coming, you know, and how could that happen? And all the key components of what we as a society say is a successful life were there. But man, there was a breakdown somewhere in this person's life that the demon of suicide got hold of them at just the right moment, and life is over. So as a layperson, let's just take it from this approach first. And you guys guide the conversation more than me, but I've got a list of questions. I'll pop out there, but you take it where you want to go with it. So let's just talk about suicide. As a layperson, what should we be looking for, and what should we be doing? For example, there was a group that sit outside where I go to get my mail, and it says help stop suicide prevention, and you know they're wanting a donation. They got a little thing there, and I kind of quizzed them a little bit. Part of what I'm concerned about, honestly, with the awareness of mental health is what's driving the discussion about the awareness of mental health, and who's going to capitalize on it for the wrong reasons and for the wrong purposes, including suicide. Now, this group may have been perfectly legitimate. Can't say that I honestly had heard about them, but yet you mix a sensitive topic like suicide with a capitalistic attitude, and you got the makings for being able to make some money and maybe not really address the real issue. So that's always been my kind of concern is, are we just using catchphrases, and where do you draw the line to say this is real, this is not? To the point of suicide, let me just ask you, as lay people, with no dog in the fight other than you're just spending some time on my show today, what do we as lay people look for to where we can be in tune with what may be going wrong in somebody's life that they might be thinking about it?
Great question. The best way to think about it is when someone looks different from their baseline, different from how they normally look. So you don't have to know every personal detail of someone's life, but it is helpful to have some awareness about, are they talkative? Are they quiet? Are they calm? Are they typically anxious? It's more about a change from the norm. That's sort of the highest level observation to make. Then, especially among children and teenagers, it's what are they talking about? Are they talking about death and dying? Are they talking about looking for ways to kill themselves? Or are they asking questions like, how many Advil do I need to take to kill myself? And then sometimes you'll hear offhand comments like from adults, like, I think I'll go home and drink my dinner, or things like that that suggest not really caring, having a fatalistic attitude, engaging in high-risk behaviors. Those are the types of things we should be looking for. Some people will say, well, we know 42% of suicides are preceded by a relationship breakup. And so they say, well, let's look for the relationship breakup. But that's not really an accurate way to do it. It's better to think about it this way. There are about 7 or 8 common triggers that might lead someone to think about suicide or attempt suicide. But the common denominator, the common piece among all those triggers, is that they lose their meaning and purpose in life. Either their identity is somehow threatened, or the reason why they're waking up in the morning is somehow damaged or jeopardized. So that's what we should be looking for, is when do people encounter a dramatic change in life that affects their sense of meaning, purpose, and identity.
Is it possible for somebody to not display any of those, and it's in their head, but they haven't shared it with anybody, and you just wake up one day and find out that they killed themselves?
Exactly. Most people are pretty ashamed to admit it. There are faith-based prohibitions to suicide and a lot of shame around that. We also use the word committed suicide. Well, we commit 2 things, sins and crimes. And so as long as that word committed stays within our vocabulary, we're actually feeding the stigma. Because it's hard for me, if I'm thinking of killing myself, it's hard for me to turn to my friend and say, hey, I'm thinking of committing suicide.
Like committing a crime.
Like committing a crime. Right, exactly. And so what we know about suicidal people is they are very hesitant to share, but if you ask, they're actually dying to share. They would love to share with someone, but they need to know that they're not going to be rejected, thought to be crazy, or somehow judged.
But how do you ask somebody that question? Because what if they're not thinking it? You know, what I always think is, they're not thinking it, well, I'm going to ask the wrong question, and all of a sudden, well, maybe I do need to, and then I got to live with that later, number one. Or number two, they get mad because I asked them that question and they weren't thinking it, and they get defensive. And I think breaking that barrier to get into that conversation with somebody, if you see one of those triggers, how do you deal with that?
Great question. So the key is just asking it directly. Are you thinking of killing yourself or ending your life? Now, it's more helpful if you start with a general observation. Hey, you don't seem like yourself. Hey, something seems different about you. Are you okay? So start high level, and then you do want to, in about 2 or 3 questions, get to that direct question. Are you thinking of ending your life or killing yourself? There's no research that says by asking that, I'm going to make someone worse, or I'm going to make someone who wasn't thinking of suicide all of a sudden think about killing themselves. So you're not going to give them an idea they didn't already have. And the way I try to help people think about it is, would you rather ask an awkward question and maybe offend someone, or miss the opportunity to help someone not end their lives? And that's a personal choice.
Well, in a pastoral role, I get people that ask me things, and I get people that ask me things that about somebody else. Well, how do I approach this subject with them, or I've got a concern. The one thing I always tell them, too, is, what would you rather live with? Would you rather live with the idea that you called 911 because you thought they were going to commit suicide and you wanted to get the help, you wanted to kind of relieve yourself of that liability, or do you want to get that phone call that, man, I should have done this. I don't want to live with the I should have for the rest of my life.
Exactly.
All right.
Exactly.
So let's go
One
ahead.
other point.
Sure.
Yeah. To your initial question was, are there times where we won't see the signs? 20% of suicides, we're never going to see it coming.
Okay.
20%, they either escalate too quickly so that we don't have time to see the signs, or they don't want to let anyone know, so they're going to actually hide the signs and so that no one can stop them. The other 80%, that's where we're going to see signs. And so that's a good thing that for 80% we'll see something coming.
Okay. I'm frowning because Heidi's already given me the mark that we're 5 minutes away from the bottom of the hour, and this is flying by fast, in my opinion. And we haven't even got to my free counseling yet. But let me do this. I want to transition now into the integrated care. Maybe that's where you're about to go, Kim. But so how does a layperson, or say somebody is identified into the integrated care, and are providers doing enough to pick up in the office or wherever the setting is occurring, could be a school counselor, whoever, to recognize those things? And go ahead, Kim, with your thoughts, and then answer my question, if you will.
Sure. Thank you, Senator Hammer. So, I think that a lot of times what's happening is just as you expressed, there's hesitancy. And I think there's hesitancy whether we're in primary care or whether we're in the school asking someone, are you suicidal? And looking at the person in front of us and starting to identify those signs. And I think that one of the things that's so important, as Dr. Corso said, is if we see something, we need to say something. We need to bring some awareness to what's happening. One of the things that we're hearing, and we know people are coming to their primary care providers and they're talking about this. They're talking about not only their general health concerns, but they're talking about suicide. And oftentimes we don't have a system that is in place where we can adequately screen them. There's a lot of discomfort. Sometimes people don't feel confident in the ability to screen them. And then if we do find out someone is suicidal, what do? We're having lots of access issues. We don't know where to send people for referral. So I think that is a huge piece. We do know, though, and I don't have the numbers in front of me, but I think about 20% of the time when there is a suicide, someone has been seen in primary care the month before that suicide. So primary care is really set up to be a system that we can actually catch some of this. And integrated behavioral health is an absolute necessary place of where we can do this.
All right, Patty, talk about, we've got a chart, and I'm going to put it up on my on our social media outlet for the Kim Hammer Show and Facebook. Talk about this chart, because that was one thing you wanted to get to, and how does it play into everything we're talking about on this point?
Right. And so one of the responses of our system is often just say, okay, well, there's a suicide crisis or overdose crisis, mental health crisis. We've talked about the fourth wave of the pandemic is mental health. And so a lot of the response of mental health providers and the mental health system is to build more inpatient psychiatric rooms and systems, or more specialty mental health. We definitely need the mental health specialists, but we need to go upstream, because most people who have thoughts of death don't really want to kill themselves, but they want some relief. And so what we believe is keep going upstream and provide training to the community, just like Dr. Corso has been doing with ABEN this week, of going to the community, providing training to lay people. We had some people in our training in Marshall, Arkansas, that worked with the sheriff's office, a dispatcher. We had someone who was a volunteer with CASA. And so by providing more training to ministers, first responders, teachers, coaches about how to respond to someone in distress, just like what Dr. Corso just said, but also more training in general about how to help people who are in distress or stress, because most people do not need to go into a mental health institution or get engaged in long-term mental health treatment. And
Sorry, got to cut you off, got to take
Okay.
a break, but that's a good point to pick back up on when we come back. And the point is, we don't want people to get that far down the road to where they
Right.
got to be institutionalized if we can do something to get them, as you said, upstream. All right, we'll continue this conversation. My guest in studio today are Kim Schuler, licensed clinical social worker, slow down, Patty Gibson, MD, and Dr. Kent Corso, in all the way from Virginia to be on the Kim Hammer Show today. Thank you all for being on here. We'll come back and pick up on this topic after the break here on the Kim Hammer Show. Welcome back to the Kim Hammer Show. Thank you for joining me here on Saturday. And my guest in studios, in case you're just joining me, is Kim Schuler, licensed clinical social worker, Dr. Patty Gibson, and Dr. Kent Corso, in from Virginia. And we are talking about mental health. We're kind of on the topic of suicide right now. We'll get to some other points here in a minute, but let's finish up our conversation, because what I want to come back on the point of what you were talking about before we took the break, Patty, was what are we doing something different as far as ABIN and what Dr. Corso is talking about? The goal and objective, keep them out of institution. We want people living healthy, productive lives in their community, in their church, in their place of business, certainly in their family. But this integrated care concept, something new, is it something different that nobody else is doing, or just give me the background there and take it from there?
Sure. There's actually been research going back 20 or 30 years that by addressing people's or patients' emotional distress, anxiety, depression in primary care, that their physical health will get better. And there's randomized controlled trials going back 20 or 30 years that shows this works. So this is a model that has been developed and actually across the world, and especially in all parts of the country. And there's various frameworks coming out and different models and programs across the country. And as a matter of fact, that's how ABIN was formed, is that we were part of a Medicare, CMS an initiative called Primary Care Comprehensive Primary Care Plus, CPC Plus. And one of the requirements was for the clinics to get the money had to have integrated behavioral health. So they were given money to pay dietitians, pharmacists, mental health professionals. And so across the state of Arkansas, as well as other places, but in the state, many places began to do integrated behavioral health. But the CPC ended, the funding ended the end of last year. So now there is no special funding for this. So the way that our mental health system is set up is that mental health professionals need to bill certain codes and be in a mental health setting. So integrated behavioral health is providing mental health care in a primary care or other medical setting like OBGYN clinic, sleep clinic. So there are places around the state that are doing integrated behavioral health. The problem is that the funding is not there to keep it going. So some of the clinics that were doing it can no longer do it because they can't afford to pay their mental health specialist. And the training for mental health specialists to do this type of work, it's a very different type of mental health care. It's different than being in an inpatient unit or in an outpatient clinic. So what we're trying to do is to provide training and teaching for the workforce, but the workforce is not going to get training if they can't get jobs when they get out. So we have to keep going upstream to get this type of care paid for. Lots of places are trying to do it, but we're all fragmented, and because it's not reimbursed consistently, the models are not consistent, and the clinics are having trouble implementing it. So what we're trying to do is to increase the training for workforce, and actually this past year, Blue Cross provided some funding to the social work schools to provide some training for the social work interns, and we're supporting that. And we're also trying to connect and partner. That's some of our offering the webinars, and to connect with the payers in the state so that they can also come together with the people who are providing the care, so that we can increase this implementation. So places are trying to do it, but it's struggling because it's not the way traditional mental health care is done. There's kind of two buckets of money.
All right, let me come back to you, Dr. Corso, because on that point, that kind of leads into one thing I want to talk about, and that is it's not the traditional way we've done it. But, the definition of insanity is you keep doing the same old thing over and over, expecting different results. So what a topic for you three. You're in the room. You can talk about that. So let me ask you, because you go around the nation, you do various teachings and seminars in other places. For those parts of the country that are adapting to this approach, the results between keep doing it the way we used to do it and have always done it versus this concept, what are you seeing as far as producing positive results, or is it moving the needle?
It absolutely is moving the needle. So just to broaden the context, the VA and the Department of Defense medical systems have been running these programs for almost 2 decades, and they're getting massive success. One of the most helpful things from a system perspective, Dr. Gibson was about to talk about funding. We know that if we have a well-trained behavioral health provider integrated into primary care, even if they're only seeing 5 patients a day, which is about a third of their maximum capacity daily, they can see up to about 15 patients a day. If they're seeing 5 a day, it will reduce the demand on the community mental health system by 30 to 40%.
But now you're getting into somebody's pocketbook.
But it's cheaper. So this is the difference between putting more smoke alarms in your house or putting more fire departments and fire hydrants on the streets. What's less expensive and covers more ground? Smoke detectors, and teaching kids and adolescents not to put metal into outlets and not to play with matches. So these upstream ways of addressing the problem produce less problems downstream, and they're cheaper.
So do you find resistance for the concept of what we're talking about as far as integrated care?
There is some resistance. What I've noticed, and this is not just in Arkansas, this is everywhere, the traditional outpatient mental health community sometimes feels threatened. But once they work with us, they say, oh my goodness, this is great. I'm getting patients who actually are appropriate for care. They come wanting to work. They're motivated because we've prepped them a little bit on the front end in primary care. 90% of the patients we see in primary care will never need to be referred to specialty care. So the throughput is the 10% that really needs that intensive care. And so they appreciate it once they have worked with us for a while.
All right, so let me give you a setting. For example, primary care physician. You go and see him for a stump toe or for, sore throat, whatever. And is the concept that you are training these primary care physicians, whether that's a APRN, a PA, a medical doctor, whatever the case may be. You mentioned OBGYN a while ago. Anybody that's point of contact when it comes to physical needs, and to train them to see indicators, such as you mentioned a while ago, or take them through the training to create that conversation in a safe environment where typically people trust their medical provider that they're going to open up and say things that they might not say to somebody else. And at that point, say something is brought up, I go in to see my doctor, I say, man, I tell you what, life just sucks lately, something like that, and they pick up on that and that conversation goes. At that point, would that person be referred out to somebody, or are you proposing that actually have mental health workers in the setting down the hall to refer them to?
Correct.
We would.
Yeah, go ahead.
I was going to say, we would absolutely love to have someone right there, and not just down the hall, but actually embedded on the care team so that they're part of the team and they're interacting with those medical providers throughout the day. We call this a warm handoff. So when the provider comes out of the room, they could quickly bring in the behavioral health consultant. They could do a quick introduction. They can transfer the rapport very quickly. The behavioral health consultant can come in. They could do a quick assessment, do some interventions, come out, give a report to the primary care provider, and the patient's on their way. And they actually have some tools to take with them that they could start now versus having to wait. So I absolutely think that that is critical. One of the things I was also going to say, and I think is so important, is mental health is still a taboo topic. And so even though we're all comfortable talking about this in the room today, when we're out in the community, it's really difficult to talk about our mental health, and there's still a lot of stigma out there. And so I just think that that's something that's important. When we're looking at health, we don't have health. There's no health without mental health. We don't disconnect our head from our body and treat our head over here and our body over there. And so I think that it's really critical in this model that we're thinking about someone comes in and we have to assess their entire health, and moving to whole health is actually going to be critical. And we all do daily behaviors. I decide, am I going to get up and have a cup of coffee, or am I going to have 5 cups of coffee this morning?
5.
And how's that going to affect me? Am I going to come in and maybe my blood pressure is elevated? And so I think that it's crucial for us to be addressing these issues. I'll stop there. I don't want to take too much time.
You look like you want to say something.
Well, you were talking about, is this competition? Actually, probably 75 to 80% of the people that, let's say somebody comes into primary care and either the primary care doctor or someone else refers someone to a mental health specialist, 75 to 85% of the people never get an appointment. It's so long. Like if we all said, let's see someone today, the wait time could be anywhere from certainly a week, but more likely a month to 3 or 4 months. And by that time, the patient doesn't go keep the appointment. So then the mental health specialist is sitting there. They thought they had a full day of appointments, but probably a third of them are not going to show up.
Well, you're hitting on a point, and that is also the shortage in the
Yes.
workforce of people that are trained. Your two professions are shrinking as far as people going into the field of being a psychologist or a psychiatrist. It's not like the people are beating down the door to get into your occupation. I know on the licensed clinical social worker too, it's about the same thing, that there is a shrinking workforce but a growing demand, which puts more pressure on the system. So to the point of what you're trying to prove today, if we could get that upstream and get it at the provider point, then, and I'll use this analogy, it's like churches. There's plenty of sinners to go around. We don't have to fight with each other. They're always going to be out there. There are plenty of folks that are going to have needs. We just need to make sure that we're effectively using our workforce and trained skill sets to get it identified sooner than later. Agree? I mean, is that
Yes.
basically?
Absolutely.
And if you think about it, it's kind of like people who have heart problems. Most people do not need a heart transplant. A few people need heart surgery, but now we've learned actually we can do stents or other things. Most people don't even need to see a cardiologist. They can see their primary care doctor or clinician and can make lifestyle changes or start on medication in primary care. Same thing with mental health. So going into inpatient mental health or outpatient clinic, that's like going to see a cardiologist or a heart surgeon. Everyone does not need heart surgery, but some people do, and we need to make sure that there are openings and availability. So if they need a heart surgery, they can get in. And if someone needs to see a psychiatrist or a psychologist in a mental health clinic, we need to make sure that there's availability, that they will be there, that they're able to keep their businesses open, and that they will have an opening in a reasonable amount of time.
Okay, I'll tell you what, I got about 14 minutes left. I want to give a couple minutes back on the suicide topic, and then I got a general list of questions I want to get on too. So when it comes to suicide, there are all these numbers from, if you're thinking about suicide hotline numbers, all that kind of stuff, which I'm not banging any at all. It's just that if somebody calls a suicide hotline number, what is the experience that they will get versus somebody that sits in the primary care office and maybe they say to the doctor, and this could go both ways, they could say to the doctor, hey, I'm thinking about suicide, and the doctor would freak if the doctor didn't know what to do or who to refer that person to. Talk about the two different results that come calling the hotline number, calling 911, or talking to a doctor that maybe doesn't know how to handle that situation.
Sure. So let's start out with the 911. So as of July of this year, we will all move U.S.-wide to 988 for a suicide hotline. Just
Okay.
like 911, we'll have 988. 13 states have already adopted it. The data so far look great in terms of uptake. Citizens are realizing, okay, sounds good. They're learning, okay, let's call this number. You can still call 911. The experience you'll get from calling 988 or the Suicide Lifeline, which is 1-800-273-TALK, the experience you'll get is good. They are highly trained people who are crisis counselors. People should never hesitate to call 988, 911, or 1-800-273-TALK. Having said that, if I can get served if I'm a patient and I'm suicidal, if I can get served in my primary care clinic where I have a relationship with my doctor, where my family comes, where I've been seen for years, that's preferable. It's preferable because, to be honest, when you talk to most primary care providers, whether they're nurse practitioners, PAs, or MDs, they don't have a lot of experience with suicidal patients. So that's where this integrating behavioral health is so valuable. It gives them this specialist in-house so that we're not having a knee-jerk reaction and just sending the patient to the ER or sending the patient to the psych hospital. We're able to, in a calm, familiar setting, open up this personal issue, this dire issue, and discuss it with the trusted team.
I ought to know this. I'm a state senator, but I don't know everything. I'll admit it. I get told a lot of times I don't know anything either. So there. Arkansas got the 980 system. Are we one of the 13, or is that something we need to?
I don't know if you're one of the 13.
Okay, we'll find out.
But
I'll get
you're
that
going to
out
be
there.
required to by July. But
July. Either
yeah.
way, we
Either way,
will
you're getting
be.
there. You
We
will
will be.
Absolutely.
Okay. Sorry, I should know that, but I don't. So I come on the show to learn stuff about myself. All right.
I just wanted to interject and add to that. I think that when we're looking at an integrated model, one of the things that happens is we have improved provider satisfaction and decreased burnout. So when we're talking about workforce, that's happening as well in these primary care clinics. We see nurses leaving, we see physicians that are struggling with their patient loads, and so this could really increase their satisfaction in the work they do.
You know, the person I referred to a while ago that I know committed suicide, very successful person, had every reason to live, kind of stuff, outside looking in, not knowing what's going on in the inside, looking out. But when you compare we think, I think some of the stereotype is you think somebody that commits suicides, loser, hooked on drugs, all that kind of stuff. Not always the case. Do you know the percentages as far as professionals, let's just say in the field of mental health, that are committing suicide? Or what population is it hitting the hardest?
So the fastest growing cohort for suicidal people are African American adolescents ages 12 to 17. So black girls, even more than black boys, are the fastest growing cohort of suicidal folks. Now behind them, Native Americans are by far 5 times the rate of any other demographic. Try to, consider a near genocide and imagine what happens to the generations of families, right? So the Native American community has the highest. Then outside of that group, we're talking about African American adolescents, and then behind them it's adults 46 to 68.
Okay, so
And all professions.
And all
'Cause
professions.
there's
Absolutely.
definitely high rates in the health professionals, physicians, psychiatrists.
well, and I used to be a medic, worked on the ambulance, and we had some, that ultimately took their life. They saw something they couldn't process, they couldn't compartmentalize, they couldn't get out. We do the debriefings after we had a couple of really bad runs. They call us all in, and we have that. I was part of that team that did the debriefing and everybody talk it out kind of stuff. Sometimes what I think happens is, okay, we did that, let's move on. In reality, the baggage is still there, and that person didn't want to come forward because we'd been through the process and you should be fixed. The reality is they weren't, and sometimes it didn't get the attention that it needed to get. Let me segue with the time we've got left. We can keep talking about suicide, but I want to expand to talk also just about mental health in general. So you talked about that, that percentage or that population where the number was highest. My question to you is this, as professionals. I'm from the generation of suck it up, put dirt on it, and move on, and I think we've done pretty good, okay? But it would appear that this generation is having more problems than the generation I grew up in. Have we created a mental health problem by virtue of the fact that there are some things that are not in this generation of society that were in the generation I grew up in? and what is it that's driving mental health issues up, and what is it that is contributing to it?
Sure. And I'll tell you my personal observations just through practice. I think that social media has been a huge contributor. There is lots of research that shows the more time we spend on social media, the higher our rates for depression and anxiety. I think a lot of times, too, with social media, we have a device in our hand and we are isolating. We're not interacting with people. We're not involved in activities. We're not making eye contact. And so all of that's contributing to the social isolation. When we hear about the highest group being 12 to 17-year-old African American girls, one of the things that I think about is what's happening on social media. And so when we look at social media, in my opinion, that's probably one of the biggest contributions of this generation. Instagram, Facebook, Twitter, TikTok, all of those.
Anything else?
What I would say is that this generation is much better at raising a flag to say, hey, that doesn't feel good. To their credit, they're great at voicing when they feel bad, but their ability to necessarily cope is a bit different than your generation, where we'd say, suck it up, just move on.
I think the previous generations and what they experienced growing up, you got World War I, World War II, you got Vietnam, you got a lot of intense situations that people, and it was pretty frequent. You look at the number of occurrences that took place in a particular generation, it was like they were dealing with something all the time. Seems like we maybe have gone into a generation where we're used to getting everything we want. We've been right, except 2008 had a downturn, but for most part, life's been pretty good. Now, you got this war going on the other side of the world that I think is rocking some people's mind, which it should. And I just wonder, in the period of our time as a nation that we have enjoyed prosperity, has that adversely affected us in that we've gotten used to something that isn't always going to be there? I mean, we got some hard times coming, and if it's this bad now, while things are good, what's it going to be like when this economy crashes? What's it going to be like when this generation gets rocked the way previous generations? And is that going to have an effect? Am I all wet, or am I halfway dry?
It's multifactorial, and the suck it up buttercup, and I'm in your generation, so we grew up like that, and we are the ones raising these children who have a lot of issues. And one of the things we found is that when people have been through trauma, and there's actually something called ACEs, Adverse Childhood Experiences, and we're recognizing that many people, so although on the surface we might see a lot of these kids, what do they have to feel bad about? But the more that we screen for adverse childhood experiences, and it could be as much as divorce, moving a lot, being around, the things that they are seeing in the news. And there have been a lot of traumatic crises happening in our world and in our society. In some ways it looks easier than back when we were there and did suck it up, work hard, and work long. So there's wisdom in every generation. So I think we need to listen and be creative and innovative, because they're also giving us some of the solutions. And that's why we're wanting to make it so that the right kind of care is given to each person in the right place at the right cost, instead of saying, well, everybody needs a certain type of care, like everybody needs heart surgery. And what we're seeing, the younger generation are using a lot of the technology. They're using peer support. And so we're finding that does help some. So that's why we want to work on training all levels of care and people to provide support.
Every generation's different, and we approach every generation differently.
I agree. And one thing, just to piggyback on Dr. Gibson's point, is all of that trauma that she mentioned, because of the internet, it's right in their faces in a way that was not the case for the baby boomers.
Yep.
So you can suck it up, buttercup. It's easy to forget it and ignore it because you're not constantly bombarded with reminders and videos and images of those problems. So there's something about our society, too, that I think makes it more likely for these things to affect our youth.
Well, and I got to wrap it up, but I'll tell you what we're going to do. I'm going to figure out how to get us 4, and we'll do a special podcast, okay? Because I've got podcasts now. I got people that do this. I didn't know, but we got podcasts now.
Super.
So you can go get my shows and go up to thekimhammershow.com, and you can pick up all the previously recorded shows. But I would like to pick this up. We'll do a podcast at a special time, because one of the things, I wanted to bring out that we don't have time to bring out is the contributing factors expanded. Yeah, it's social media, but what about the lack of spiritual presence? Because there's a great decline in the church right now, and COVID has become a convenient excuse for people to check out. And, I believe we are created body, soul, and mind in the image of God. And when you don't pay attention to one aspect of that, that's where you're going to be targeted by Satan, and he's going to come in and hit you. And mental health is not the exception. Look at Job and the mental strain that was put on him. You lose your kids all in one day. You got all your prosperity wiped out in a short period of time. That guy should have been in a nut house, but he was in the church house. And so those are kind of some of the things I want to expand and have a conversation. I've got to wrap it up. I got 1 minute, but I want to thank you very much. My guests today have been Kim Schuler, licensed clinical social worker, Patty Gibson, MD. We all serve on the same board of ABHIN. Hey, real quick, how do they find it? Hurry up.
ABIN.
ABIHIM.
Yes, sir. Arkansas Behavioral Health Integration Network, and we do have a monthly webinar the second Thursday from 8 to 9 a.m.
All right,
On our
now-
website.
On our website.
On our website.
I'll get that all shared. And then Dr. Ken Corso, thank you so much for taking time. I know you're in helping these ladies out, helping the cause, and really appreciate you taking time out. Not every day I get a guest in studio from Virginia. Hey, how about that? So
Happy to be here. Thanks.
thank you all very much. You've been listening to Kim Hammer Show. Hope you have a great rest of the day. We'll get information up on the website about that podcast, and hope you have a great day. And also stay physically, spiritually, and emotionally healthy. And if you think that you have an issue, go see your primary care doctor, a good place to start. Thank y'all.